Honor to introduce our next speaker, Melinda Burnworth. Melinda, she graduated from the University of Missouri Kansas City School of Pharmacy and completed ASHP accredited residencies in pharmacy practice and adult internal medicine at Grady Health System in Atlanta, Georgia. She is a hospital pharmacist, a professor of pharmacy practice at Midwestern University College of Pharmacy, Glendale campus. Melinda is involved with teaching several hospital-based courses and an elective course about rare diseases at the College of Pharmacy. She has special interests in orphan drug development, orphan diseases, effects to minimize drug shortages and maximize patient safety, as well as political advocacy, student mentorship, and women in pharmacy leadership. Melinda is actively involved with the Arizona Pharmacy Association Health System, SIG, previously serving as the chair of the Health System Academy, and is actively involved with the American Society of Health System Pharmacists and National Organization of Rare Disorders. I think you're going to love her presentation. It's going to be really interactive. Please help me welcome Melinda.
Well, good afternoon, and hopefully food coma does not set in on us during this session. So I kept that in mind when I was preparing my presentation today. And for many of you, if you've already looked at the slide set, you may have noticed that there's only 5 total slides. So the key is we are going to have audience participation, and we really want to empower you in a safe area to share your stories about advocacy. So with that being said, I did want to build off of what Michael shared about my bio today. So hi, my name is Dr. Mindy Burnworth. I'm a hospital pharmacist by training, but I'm also a full professor of pharmacy practice at our local College of Pharmacy right here in Glendale, Arizona. But what you don't know about me is that I am the auntie to a rare niece who blessed us for only 12 days. So you see, I do have a connection to rare disorders like many of you. So my goal today is to be able to share with you some of my lived and personal experiences in order to get you more comfortable with advocacy. And one of the ways that we're going to do that is we are going to leverage what I like to call our 1-minute legacy. But before we get there, I think it's important that we define what is advocacy. Oh, and I guess I need to make sure that everyone knows if you do have questions, make sure to use that slido.com or scan the QR code. So I went to the trusty Merriam-Webster dictionary, and I pulled this definition, what is advocacy, directly from there. And if you look at advocacy, it is defined as the act or process of supporting a cause or a proposal. But I have to tell you that many people, when they think about advocacy, unfortunately, there is a negative connotation associated with it, especially if I put the word political advocacy in front of it, right? There's like that, oh, it's almost like Mustafa with the Lion King, right? So political advocacy, it doesn't really leave you with that warm and fuzzy feeling. But when you think about advocacy, it simply is story sharing. Sharing a story about the beauty of your life experiences. So I do have a member of our audience this afternoon that I'm going to call on to share what is her definition of advocacy. So if I can invite Erica from Southwest MG Association. If you want to share with us what's your name, your connection to RARE, and then what is your definition of advocacy?
I'm Erica, and I'm from Southwest MG, Ohio. And advocacy to me is that standing up and talking to your doctor, going to your doctor, giving them a good definition of how you're actually feeling. So filling out maybe your ADL scale on your own before you go, so that they're getting a good idea of how you're feeling before you're actually there, and not just when you're there, because they're really seeing a glimpse of how you're feeling while you're there, but not all the time. Also, when you're going to other doctors, taking maybe like the cautionary drugs with you. Not all doctors are comfortable or know everything about MG, like your dentist. And so printing off those forms and giving them what is MG, so they're not always looking it up on the computer in front of you. So handing it to them so they know what they can give you and what they cannot give you, because mistakes do happen. In fact, those happened just recently to me twice. So even giving them those papers, it can happen. So making them aware of those things, standing up for yourself. Those are things that you can do just in the doctor world. Same thing with like your insurance. You can call your insurance when things aren't getting approved and stand up for yourself there, and help things get approved. So that's advocating.
I think we should give Erica a round of applause. So Erica has shared with her her idea around standing up for herself and sharing with providers and even other individuals about her lived experiences with going through the insurance navigation process, or communicating your signs and symptoms to your medical provider. But when we think about advocacy, there's actually many different layers of advocacy. And this is one thing that I really discovered when I became involved with the National Organization for Rare Disorders, or NORD. I am the volunteer ambassador for the state of Arizona to the Rare Action Network, which is powered by NORD. So in my role as the volunteer ambassador for the Rare Action Network, I have the opportunity to advocate on an individual level within health systems and hospitals, also at the state level, all the way up to Capitol Hill in Washington, D.C. Now, you know how I said that there was probably a negative connotation associated with advocacy? You're probably looking at all of these stages and you're like, oh my goodness, you mean I have to do something at Capitol Hill? Like that is, am I going to be able to do that? That's higher up, right? But I encourage you to really start at that grassroots level, at the individual level. And I feel like one of the best ways in order for you to get comfortable with advocating at the individual level is to share your lived experiences. So I'm wondering if my friend Carol from Mesa, she's still in the audience. Oh, I see her hand back here. She was sharing with me an amazing story during lunchtime. And Carol, if you could introduce yourself and share with us your connection or your story with MG, and then what was your ask of your provider?
Okay, hello. My name is Carol Maka. I live locally in Mesa, Arizona, and I was diagnosed in 2017. And the issue that we were talking about was my recent effort to find a new primary care provider. I had been with a doctor for a long time that understood my process of going through the MG experience, and he saw my progress and all the efforts that I regularly make to manage my disease, and he was helping me with that. When he left the practice, I was assigned to another doctor that had a different approach, and it wasn't working for me, so I went on to essentially interview PCPs. After looking online, I decided it was necessary to meet with the individual doctors, explain my specific approach to my disease and my life, and see how they react. They, in particular, found it to be unusual, uncomfortable. All of them asked me, why are you here? What do you want from me? And basically my answer was just to see if we're a good fit. So it was like an audition or an interview. I didn't say that, but eventually I found a doctor that didn't know a lot about MG, but he was open to my discovery process. And I do so many things to support improving my health. And none of the other doctors that I spoke with seemed to have a focus there. They were more interested in the fact that I'm a senior citizen and am I having dementia, and, you know, how's my blood cholesterol, and my bones, of course, you know, prednisone, there's a bone issue. But this particular doctor told me that he found me interesting. He called me a zebra, and I thought, okay, I can work with this guy. I need a partner that's going to direct me in a safe way to manage my health. And even though he didn't know a lot about MG, he was open. He's an older doctor. I was really pleasantly surprised, and I now have a new doctor because of just advocating for myself and saying, this is what I need, and not being intimidated by the response of, what do you want from me? And just seeing if I could talk to that individual doctor.
Yeah. Would you like to?
Carol, thank you for sharing that story. Two key things that I wanted to add on to. Number one, this was another example of advocating for yourself. And I love that you shared with us the idea of a zebra. So I think we're all zebras in the room, right? Do we know that the zebra is the mascot, if you will, for rare disorders? And every zebra has a unique stripe pattern. So much like every individual patient has a unique story and potentially a unique individualized medication with them. And do I have my friend Paul in the audience still from Kansas City, or did he step out? Is Paul still there?
I don't think
Oh,
so.
maybe he stepped out, but I will, hopefully I do his story justice. So he was sharing with me that he was in the health system or the hospital setting, and he needed to have infusions of immunoglobulin. And it just so happened that that facility did not have an outpatient infusion clinic. So he empowered the health system with the potential savings that could occur, the monetary or the financial savings that could occur if the facility invested in developing an outpatient infusion center. And this was a success story because Paul did share with me now that hospital or health system does have a freestanding infusion facility. So good job to Paul. So, by a show of hands, has anyone had the opportunity where they have contacted their state House of Representative or state senator? And I'm going to raise both of my hands here. I see a table full of hands over here, sprinkling over this way. So I just had the opportunity 3 different times. I went down to the state capitol and I provided my 1-minute testimony, if you will, on the importance of developing a rare disease advisory council within the state of Arizona. And I wanted to share with you this idea behind kind of sharing your legacy. One thing that I discovered is when you are talking with a representative, they oftentimes are very short on time, right? So you have to be able to effectively convey your message and tell your story in a short amount of time. And in this folder here, this is my clear protective sheet that I carry with me anytime I go to a rare event or down to the state capitol. And within this particular folder, I have 3 different testimonies. And those 3 different testimonies are based off of me being able to share my story in 1 minute, 2 minutes, and 3 minutes. So let's think about, you're in an elevator, right? The elevator probably has 5 or 10 people in it, and it may take you between 1 or 2 minutes to navigate between the different floors of the building. So if you were trapped in an elevator with your House of Representative or your senator, what would you want to share with them? And I don't know if you caught on when I was inviting our audience participants to share their story, I preface their words with, please share with us, who are you? What is your connection to RARE? And then finally, the next thing that we're going to add on to that is, what is your ask? So how can we make the lived experience better for individuals that are experiencing MG? So what I would like to do is, for the next 3 minutes at your table, I want you to discuss with one another, what would be your 1-minute legacy story? If you were in that elevator and you were in there with 4 other people, much like at your table, how would you share, introduce yourself? Who am I? What's my connection to RARE? And what is my ask? And then what I'm going to do is, after we take that 3-minute kind of discussion period, I will ask for a volunteer to share with me their story. And I'll even play the part, of the President of the United States or the Governor of Arizona. Okay, so I've got my timer on. We have 3 minutes. One-minute countdown. 30 seconds. Ding, that's the end of our 3 minutes. And guess what? Welcome to the Arizona State Capitol building. You were in the elevator and you rode those 8 floors up to the governor's office. And you are waiting very patiently for the governor's assistant to call you in to share your story. So I already have an individual that I'm thinking I'm going to have share their story, but I'd like to have one other person volunteer to share their story after Ani from Rhode Island shares his 1-minute legacy of who am I, what is my story, and what is my ask. So Michael, if we could have you share the microphone with Ani. And then we will get one other audience volunteer as well.
Hello, Congresswoman. Ani Mitra from Rhode Island. I am a college professor, 43 years old. I am a lifelong learner, diagnosed with Myasthenia Gravis in 2011 at a time when I knew nothing about the disease, a direct beneficiary of the amazing research that happens in the United States and all over the world. And direct beneficiary of the work that organizations like Myasthenia Gravis Foundation America and other organizations do in this country. My ask to you is to ensure that any major changes coming in the way NIH fundings are administered involve deliberations, sincere deliberations with research scientists, the folks who are actually doing the work. Thank you.
Ani, thank you for having that courage to share that 1-minute example with us. And I will play the part of the Congresswoman. How best do you think we could do that on the state level? Should we develop maybe advisory council for MG? Or what were your ideas?
Now you're putting me on the spot. I think start with talking to the folks who are doing the research in the labs, making sure that you understand their needs. For example, why are the indirect costs what they are? Maybe they need not be the same or what they are at the moment, but before we come up with particular amount, a dollar amount, understand what an institution and its scientists need to do the kind of work that directly benefits patients.
Well, thank you. I think that's something that we can invest in at the state level. I'm the most amazing Congresswoman, right? Okay, is there anyone else that would like to share their 1-minute story? Do we have another? Oh, I see somebody pointing over here, possibly.
Hi. All right. Hi, Congresswoman. My name's Allison Buchanan, and I heard you give a speech earlier this year, and it reminded me that I live in a zoo and I take care of the zebra exhibit. And zebras have a unique stripe pattern, just like our fingerprints and just like people with rare diseases. My son has cystic fibrosis. My dad had bullous pemphigoid, and my husband has myasthenia gravis. So my ask to you is that you would send a representative to every fundraising event that goes on and meet the people that are dealing with these diseases, because each one is unique and rare, and each one is just as important as the other. Thank you.
Wow. Many different roles that you are playing right now. So I may not be able to promise that we can get somebody there for every event, but is there one event in particular that would be most meaningful?
Yeah.
So that
Currently a fundraiser for myasthenia gravis, so that the research funds made a direct impact on my son with cystic fibrosis, and I want to make sure those floodgates are open.
Well, I appreciate you coming and meeting with me today, and I'm going to put this on my calendar, and I'll see if one of our assistants is able to come to that MG fundraiser. Thank you for making me aware of this. So we're kind of illustrating the art of negotiation, if you will, or being able to converse back and forth. And sometimes you may only have 1, 2, 3 minutes to share your story. And thank you for being very concise. Your ask, your ask was amazing. I would like to see a representative at a fundraiser. So I think if you can start with one ask versus changing the world, those little bit of successes that we can ensure, those are our steps towards really seeing long-term meaningful change within the rare community. So with that being said, I wanted to share with you that before I had that personal connection to rare, I feel like there was something that was holding me back. And it was kind of do any of you have teenagers? And they talk to you in text language? And they suffer from FOMO, which is fear of missing out if they're not on their phone and not on social media. The adult version of that is fear of the unknown or fear of information uncertainty. And I wanted to share this with you as kind of an individual example of advocacy. Even though I am a healthcare professional myself, anytime that I go into a new healthcare experience, I actually preface my interaction with whoever I'm working with. Pretend like I am not a pharmacist. I am your everyday mom, your everyday patient, and I want you to share with me all the different steps in the procedure. So that means if I'm at the dentist's office, I want you, because I can't talk at the dentist's office, right? They always have their fingers in your mouth. So I'm like, as you are picking up a new piece of equipment, as you are starting that drill, I need you to vocalize and verbalize to me what is happening with the procedure. This is my voice. This is my ask. So I will leave you with encouraging you to find your voice on your commute back to, if you are flying back to your home state. Take an opportunity to write down your 1-minute legacy or your 1-minute story and keep it handy. Put it in your pocketbook, put it in your purse. Better yet, put it in an electronic notes on your phone, and you will always have that with you. And when you become trapped in the elevator and it just happens you're with the president or a congressman or a House of Representative, you're going to make your ask on the spot. So with that being said, I wanted to wrap up with empowering you several different resources that you can leverage. My best advice for you is to find a mentor. Find someone that has already done this. And I think that's the beauty of our national patient organizations, such as MGFA and NORD. They have individuals that are trained in helping you create your story and giving you those talking points that you can use to advocate for yourself and advocate for others living with MG. And it's also important to recognize what state resources you have available to you. So I wanted to do a little bit of show and share with you some of the resources that I have discovered right here in Arizona. And one of those resources is Arizona Bill. And if you look at this, this is actually a cartoon character in the state of the shape of Arizona. And if you ever wonder about how does a bill become a law, Arizona put it into a Wild West cartoon for me. I can totally understand this. So, and then one additional resource, and I bet you your home state does have a similar cartoon or maybe even a YouTube video that talks about how do you make your voice heard at the state level. And then know about all the other hidden resources. This is our little pocket-sized green book that we have here with the Arizona legislature. And it tells me based off of my zip code, who is my House of Representative, who are these senators, and it also gives me a little bit of a bio or a background about the individual that we have voted into office. So these are kind of my two go-to resources that I keep with me, along with my 1 minute, 2 minute, and 3 minute testimony. So with that, I want to wrap up with thanking MGFA for inviting me to share some pearls regarding advocacy. And thank you, everyone that is here in the audience. You are the thought leaders. You are driving change in the MG community, and it's amazing that you're here in person. And I also want to give a shout out to all of those that are virtual as well. So with that, my name is Mindy Burnworth. I am a grassroots rare advocate, just like each of you. And we will open up for any questions. Oh, we've got from Anonymous. I use my 30-second elevator talk when seeing a specialist. I practice it out loud ahead of time in case I'm nervous. I'll give you a secret. I actually practice mine in front of the mirror, or I park my car in the parking lot and I'll turn the rear view mirror to where I can look at myself. And then I practice my 1 minute scenario. So Anonymous, you get a gold star. And if you were here in person, maybe you are, I have some vinyl stickers up here with zebras on them. Ooh, I like this next one. How can we advocate for pediatric patients with severe refractory MG when insurers begin denying life-saving therapies that have prevented respiratory failure? First off, thank you for having the courage to share that question. My best response would be to leverage the MGFA NORD. There are several different national initiatives, Fail First Therapy, trying to broaden insurance coverage, and share that experience, share that story with your national advocacy group, so that way they can filter it back to the representatives. And I don't know if we have time for any more, but You can always email those to me or share those with the Myasthenia Gravis Foundation. And I will go ahead and turn the podium back over to Michael.
Well, as some of you know, I'm not Michael. I'm a Michael wannabe. Good afternoon. I hope everybody's ready for our next presenter and our first patient panel. It should be very interesting, and it's all about the patient and their path and their journey. My name's Craig Strenger. I'm Vice President of Operations and Strategic Development for the Myasthenia Gravis Foundation. And I am truly honored to bring up our next presenter, who you've seen once before today in a cameo role with Dr. O'Connor. So Dr. Gwathmey is an associate professor of neurology at Virginia Commonwealth University in Richmond, Virginia. She studied neuroscience and behavioral biology at Emory University in Atlanta, Georgia. She then attended Eastern Virginia Medical School in Norfolk, Virginia. Her neurology and clinical neurophysiology training was completed at the University of Virginia. Following this, she completed neuromuscular medicine fellowship at both Brigham and Women's Hospital and Massachusetts General Hospital in Boston. At the University of Virginia, she started a multidisciplinary MDA clinic, was co-director of the ALS clinic, and was the fellowship director for both neuromuscular and clinical neurophysiology fellowships. She joined VCU in January 2019 and currently serves in the capacity of Neuromuscular Division Chair, Neuromuscular Medicine Program Director, and EMG Laboratory Director. Dr. Gwathmey sees approximately 100 patients with myasthenia gravis, serves on our MGFA Board of Directors, and is a member of the MGFA Medical and Scientific Advisory Council. So please give a big hand and welcome up Dr. Gwathmey. And Dr. Gwathmey will introduce her panelists.
Is this on? Can you all hear me? Yes, I think you can. Thank you. Thank you for the very kind introduction. It's Norfolk, by the way. Just kidding. Just want to see, is Randy out there by chance? Oh, come on up. Okay. So when I was asked to help give this talk, The Path for You Shared Decision Making, I decided that it would be more appropriate to share the stage with a couple of patients. And so I have Randy and I have Janel with me today. And so come have a seat, come on up. And so as Janel's coming up, Randy, can you give us just a couple of lines on who you are, where you're from, and we'll talk about your journey in just a moment.
Okay, sure. My name is Randy Clough. I'm a CPA. I've worked in public practice, currently with the PGA of America as tax director. And my journey with MG started about 7 years ago when I first started to get symptoms. And then I was diagnosed about 3.5 years ago.
Excellent. Thank you for sharing that. And Janel, if you don't mind just giving us a couple of lines on who you are and where you're from, and then we'll talk to you about your journey in a moment.
My name is Janel Worcester-Brown. I'm from Maine, and I worked 20 plus years as a social worker, and I was diagnosed with a lab test in 2019 and found treatment in 2021.
Thank you so much. And so starting with you, Randy, if you don't mind just telling us a little bit, if you don't mind sharing, about the symptoms that you began to have when you started to seek medical attention and kind of what happened from there.
Yeah, so originally I experienced eye drooping and tongue fatigue, pushing food in my mouth and speaking. You know, at work, my wife told me, you have to tell people you're not drinking during the day. If I had a meeting more than about 20 minutes, I would just start losing my voice. at the time, my doctor first sent me to an ENT, and the ENT didn't have the greatest bedside. He walked in, he said, "Why'd your doctor send you here?" And I was telling him my symptoms, and he goes, "I don't know why you're here. You've got MS or something." And he walked out of the room. So that started my shock therapy, I guess. I took that, went back to my general practitioner, and he actually sent me upstairs to the neurologist. And she originally thought it was a Bell's palsy presentation because I had just suffered a severe UTI. And from that point, it took about 3 more years until kind of post-COVID, when I was getting more active again, that I started to get, I guess, what I would say, moderate generalized symptoms.
And who ended up diagnosing you then?
Yeah, my initial neurologist did.
Okay.
Yeah. Shout out to my wife. My wife's friend actually diagnosed me about a year in, and I had one of those meetings with my doctor. I said, "I hate being this kind of patient, but I was kind of on WebMD, and my wife has a friend, and yada, yada, yada. And we all think I might have MG." And she gave me a couple of quick tests, can you look up and hold your eyes up? And I guess I kind of passed those. And she said, "No, those people are crazy. You don't have that." But
Well, thank you for sharing. And Janelle, can you tell us a little bit about your symptoms and that long journey? I understand
was
getting a
actually
diagnosis.
probably maybe 2010, 2013, that area. I really started having, I didn't realize it was ocular symptoms, but my left side was very droopy, and my balance was off, and my legs were very weak. My quads were very weak, and which affected my balance. But I was working a lot of hours, and I was going to grad school full time and loving every minute of it, but it was taxing. And so I attributed everything to that. That was like early, right? In 2015, I stopped working, and it was immediate. I was not able to use my body. And that lasted for a while, and there weren't any answers. They thought it might be MS. I was treated for chronic Lyme with medications that actually made me very, very sick. As you know, there are black box medications we shouldn't take. And then I also was a little Google MD. And I really felt that my symptoms corresponded with MG. I wanted to look at myself as a case study and not with all the emotions involved. And I tracked symptoms, and I tried to learn as much as I could, not only about what possible diagnoses, but what was going on with me. And it was very life-changing, to say the least. And when I saw this neurologist for the first time, I mentioned the idea of MG, and she said I did not have it. And she would test me for it anyway, which I appreciated very much, because she could have said no. And then she said I definitely needed psychiatry, and that I looked sleepy, and I was devastated. I felt like my integrity was very much attacked. And she treated me with Mestinon and sent me for a second opinion, and my nerve testing was normal. And so they stopped my treatment.
Well, thank you for sharing that. I think kind of in follow-up to these stories, I'm first going to start with asking both of you, have there been times, and you've already alluded to this, that you've had interactions with physicians where you feel like you weren't being heard, or things could have gone differently and the outcome would have been different? And so I think you both have already volunteered that in the first few moments, but other examples, Randy, of conversations that you've had with providers that could have gone differently?
yeah. So one thing I liked about my initial doctor, once I was diagnosed, and I saw some of the treatment protocols and stuff, I was very anti-prednisone out of the gate. I had a father that had some severe side effects to it, and found my father had vasculitis, which is another autoimmune. So if autoimmune was within my family, I was concerned that prednisone side effects might be within my family. So I kind of said, no, no, no. And she advocated for me and started me on Mestinon, but skipped the whole prednisone CellCept kind of protocol. And she did it all, fortunately, but she had difficulties getting the insurance to go past that stage to the IVIG treatments, but she successfully did. So I guess what may have been different, I think, prednisone CellCept is kind of a typical protocol, and I'm just fearful had I gone down that road, what kind of side effects I would have suffered through that process. But
So in that situation, you did feel heard by your provider because they opted out of using prednisone and
exactly.
CellCept and then bypassed that. And so
Right.
that was a very successful discussion you had.
Very positive.
Very
correct.
good, very good. So Janelle, either positive or you provided some negative examples, but
Well, in the last 10 years, I've seen probably 50 neurologists and many other specialists. It seems like once that happened, more specialists got on board, and I was previously very healthy. But I think there were many, I used the MGFA's information. I was very, I read a lot about it, and I knew the information that neurologists were sharing wasn't up to date.
Mm.
And it took hearing a doctor in Florida online and hearing him say the things that I was reading, and I couldn't wait any longer. I knew I needed to have treatment, and so I went to him. He listened. He educated me on the treatment options. I've had doctors ask me, well, what do you think? And when so much control is taken away from us, we're very vulnerable. And neurologists, doctors, they're the experts, and they're people too, but they're the experts and we want their help. But I don't know if they understand how much, how vulnerable we are in their hands. And just to feel heard, maybe what we want isn't going to happen, and there could be very good reasons for that. But just how you make someone feel is going to make a lasting impression much more than what you tell them to do or what have you. So I think just having, those educated doctors really made a difference. And I'm happy to say that after 10 years, which is 10 years being here, actually, it's been my 10-year marker. I've come a long way, and I couldn't have done it without that doctor in Florida. Not everybody has that option. But I could not settle until I found doctors that were educated and knew.
and I think for the audience, I mean, just to point out what you're saying, you really advocated for yourself. And it was like this tireless journey to find a physician that listened to you, that you had a good rapport with, that you trusted to help make medical decisions moving forward, right?
Yes, and actually just last month, I found a doctor 3 miles from my house, so I don't have to travel
More
to Florida
convenient.
just to visit instead.
Yes. Okay. Very good. So, so Randy, would you tell me a little bit about how your neurologist explained the diagnosis of myasthenia gravis to you? Because I'll tell you from my practice, what I do is it's usually at least a 30 to 45-minute discussion on what myasthenia gravis is. There are a lot of, my MG guidebook that some of the MGFA folks know about. I give that to them. I go through everything, the pathophysiology, treatment algorithms, and all of that. How were you told what myasthenia is and what the treatment plan would be?
I think I was already sort of advocating for myself prior to my diagnosis, educating myself a bit. Once I was diagnosed, my first neurologist, I think I may have been her only MG patient. I think she was fantastic, and got me off on a great start, but she didn't do much in the way to introduce me to what it was or where there might be help. I pretty much did that all on my own. So she didn't have like a kit to send me home with, or, pull up the computer with any explanation of anything. I learned all about these charts we saw this morning, through primarily our community group and online stuff.
And Janelle, in terms of like the first maybe 15 neurologists you saw, how did the neurologist who finally made that diagnosis educate you about what it is? Or maybe the neurologist in Florida, how did he or she educate you?
Well, it was definitely the neurologist of Florida. But he actually got out a piece of paper and drew it out. And yeah, I'm very visual, so that was a wonderful thing for me. But, and also, he handed me the pamphlets of different medication options and different treatments and wanted me to think about it and see what made sense to me. And it was a lot of information, and 10 years later, I'm looking at the slides this morning. I'm like, okay, these are familiar now, finally, right? But it is a lot of information, but he did take the time and explained it. And I felt reassured, and it did help build that trust that he took the time to explain it. And when I was told no, and even after I saw him and was still trying to find neurologists closer to home, thinking, I've had my thymectomy, I've had this positive treatment, it would be easier. And it still took some time, but I think just providing that information and the patients and explaining it was really helpful.
And so thank you for that. And Randy, from your perspective, are there certain resources that we as the providers should be providing to patients that are newly diagnosed? What would be helpful? Would it be helpful to draw out the neuromuscular junction, as it sounds like Janelle received, or what do you think?
Yeah, I'm a little bit of a nerd, so that kind of stuff helps me. Like Janelle said, to see it in a picture and understand what's going wrong there. And I think that helped me too. I think through the resources on MGFA, I found a trial. Once I understood about the disease a little bit, I found a trial that I was really interested in. And I went to my neurologist and said, hey, I'm thinking about, doing this. And fortunately, that trial was available, 30 minutes from my house through another neurologist's office. And my first neurologist was very supportive of that. And so I kind of went that route, again, through information from the MGFA site, I think, pretty much.
Okay, that's helpful. I would say, as I educate my new patients, and I see sometimes several per week, what we'll do is I'll give them a piece of paper at the end of our discussion. I'll say, this is my diagnosis. It's seropositive, non-thymomatous, generalized myasthenia gravis. These are my medications. These are online resources such as the MGFA that you can reference, or clinicaltrials.gov to find a clinical trial. And, so then they can kind of carry that around with them and reference it in the future. Oh, okay, I do have AChR positive, antibodies, for example. So I think some of these very, it could be a concise discussion, I think, to really just say, here you go, this is what you have. And that way, when you're looking at trials, for example, you know what you qualify for too, as well. Yeah. So when it came to the IVIG, which it sounds like you started, how did you all decide on that treatment? I know you said steer clear of prednisone and Cellcept, but, was that a decision that you all came to together? Was the rationale provided to you?
Yeah. Well, I think the IVIG was all my neurologist. And since we were kind of skipping the prednisone protocol, I think that was the next step in the protocol line at the time. And I was just anxious to try anything, I think. I positive results from the Mestinon from like the neck up with my eyes and my tongue, but, you know, looking for something to help out from the neck down. So,
And did your provider communicate the possible side effects or complications from that treatment and what would be expected with these infusions? Do you recall those details?
yeah, that was laid out pretty well, I think. And I didn't see any, obviously I felt the pros outweighed the cons at that point in time. And she was good at explaining that, at least in her mind, that, you know, IVIG isn't a long-term solution. So even at that point in time, it was like, well, let's do the IVIG. Let's try to, you know, reduce your symptomology and then go from there. So it's kind of a step, I think, in the process.
Thank you for sharing that. And Janelle, for you, beyond the Mestinon, you know, when it came to choose a medication, how did that go? How that discussion?
Well, honestly, I really did trust my doctor because I knew he was knowledgeable, and so I was not the expert. I trusted his opinion in that, and he did explain what the side effects would be. And I also started with IVIG, and it seemed like that was like the safest way to start, you know. And now there's so many more treatments to choose from, but yeah.
Right. I completely agree with that statement. And so I get asked all the time, you know, how do you decide what medication to prescribe your patient? And I always say, for me, it's really just presenting my patients all of the appropriate options, right? So as we touched on earlier, for unfortunately our seronegative patients, there is not a menu necessarily that I can provide to them and choose from all of these newer therapeutics. But for our antibody positive patients, there are a lot of options on the table. And I think it's really our job as the physician to present all of the options and say, these are the pros and cons. These are the different, you know, treatment schedules, the different routes of administration, and then together come up with a plan, right? And so I also am not going to offer you something that might be, you know, not in your best interest. And I might say, this is why I don't think this is a good choice for you. Back to the prednisone, right? So, I'm not saying you are diabetic, but if I had a patient who is diabetic, I might say, you know, prednisone is just really not a good choice for you in this situation because of the side effect profile. Let's look at other options, and here they are. So, yeah. And so have either of you pivoted to different treatments since then? And so then how did those discussions go?
Yeah, I'll start. So I did get in that first trial. It was like an apheresis trial. And that was through a different research group with a different neurologist. And it was kind of a quick decision at that point. I'd love my first neurologist, but it's like, I think I have a better team option over here. Because it was not just the neurologist, but it was his research team also that, you know, sometimes they could spend more time explaining things to me. The doctor doesn't always have all that time, right? And in addition to that, what I found out through the trial process, the research group had one infusion room. So when I'm there getting my treatment, I'm usually there with 2 or 3 other MG patients, and they're getting other treatments, and we're sitting in there, you know, hey, what are you on? How's that working? How long, you know? Yeah. And then we get to talk to the doctor comes in the room, and it's like, hey, okay, I've been doing this for 6 months. You know, he's doing something else, and I think he's doing a little better than me. He goes, well, we can talk about that. So that really took it to a new level for me. And I actually went through 3 different trials. And you know, each time the first trial, it was interesting since it was my first trial. I was like, I was committed to it. It's like, I'm part of this scientific thing going on. And partway through, he was saying, you know, we're not seeing any improvements. What do you think about getting out of this one? And I'm like, what? You know, it's like, don't they need this knowledge, don't they have to finish the study on me? He goes, it's not about the trial, it's about you. And your symptomology isn't getting better, so we need to move you on to something else. And, at that point, the neurologist had me, I knew he was on my side, my team. Yep.
Thank you. Janelle?
Well, if nothing else, MG teaches us patience, or tries to anyway. And I know when I felt the IVIG wasn't working any longer, or the side effects were just really too much, it was something that I had communicated a number of times, and eventually we had the discussion, and it took a few visits, and then I started a different treatment, and I was thinking, this is a horrible, it's not working. But when I look at the past year that I've been on it, I really have made the gains, and it's having that hindsight and looking back, and we all want to be back in our original form, right? But
So when you did eventually switch from IVIG to your current therapy, were you given a lot of different options, or was it recommended that whatever you're currently on, which you don't need to mention specifically, is the best choice for you?
he did recommend that treatment, and it was something that I had been interested in. So I was cool with it.
Okay.
Yeah, so it worked out well.
Excellent. And so anyone who has ever worked with me knows I'm a very big believer in patient-reported outcome measures. So whenever a patient comes into clinic to see me, they get the MG-ADL, which you have heard many times today, the Activities of Daily Living Scale, and then also the MG Quality of Life 15R scale. And so my patients actually self-administer these. They go ahead and fill them out before I even go in the room. And I track these scores over time in the electronic medical record to help inform me if I'm doing a good job or not, right? Taking care of my patients. And so I do trend these scores and look for therapeutic response. And if I'm not seeing, the results that I want to see, that will certainly give me, enough information to approach the patient to say, okay, maybe this isn't working. Let's go back to the drawing board. So my question for both of you is that been part of what you have partnered with your providers on, like using these patient-reported outcome measures like the ADL? And I'll start with you, Janelle, because I already kind of know the answer.
Well, I like that 15 as well, but the ADL, the MG-ADL score, yes, I do that on a regular basis every week. I can't do that daily. I cannot focus on doing that daily, but I do it weekly, and it does give a nice perspective when you can look back at the graph, because there's a graph to kind of see it. Because again, I'm visual, right? But initially that was not used, but then as time went on, it was, and it's at every appointment, and that I do enjoy that. Yes, very much.
Okay, so in addition to you self-administering the ADL on a weekly basis, your provider also gives you the ADL when you're seen in clinic, and then that's trended over time.
I share that when I go into the infusion clinic, and then obviously when I go to my doctor, he does that as well.
I was going to say, I've gotten a lot of spreadsheets from patients of all of their scales and scores, and a lot of data can be a bit overwhelming from a provider standpoint, but it's also extremely helpful. So I love that. How about you, Randy?
Yeah, I've done a lot of ADL scoring. Through the trials, they also did some muscular testing on a regular basis, which they can't really share the trends or data with me, but obviously I'm there when they're doing it. So I got a sense of I guess I got a sense of them from a more muscular perspective, how these drugs were helping or not helping me. And I think I'm a more results person. So that was a little more helpful to me. The ADL, it's like, how's it been for the last week? Well, I could have 2 days that were bad and 3 days that were good. Well, how do I score myself in that situation? Did it happen once? Yeah. I bit my cheek, so I know my tongue was weak again or something. But it's interesting. It recently on the new medication I'm at, I've noticed an improvement in the ADL score, which has kind of surprised me. So although I'm not a fan, I may be becoming more of one.
Well, I think you bring up a good point that the ADL is subjective, and then some of these other, outcome measures we use in clinical trials are more objective, right? Like hand grip, strength and things like that, breathing numbers. And
Yeah.
so if you're a very data-driven person, you might prefer the objective instruments.
It's a
But
CPA. in me.
exactly, right. I bet you have spreadsheets too.
Yep.
So just in the event you start feeling poorly, this is again just a hypothetical. If you were to get a cold or the flu and your symptoms were flaring and you needed to reach out to your provider, how would you do that? And what would you expect the response to be?
Fortunately, I haven't had that. I've not been in crisis since I've had MG. But my doctor has been very reachable. I've got his direct number if I need it. I try not to use that. I've got the direct number of his assistant, which I know is the better route to go. I can get a hold of her, explain things to her, and then I get a call back. So that's kind of how we work it.
That's excellent. How about you, Janel?
Well, my current new neurologist, his communication is phenomenal and very thorough. So I feel comfortable messaging him through the portal and getting a response and it being clear. It's amazing. But also I feel comfortable calling the office, and if it's more urgent, I will call the office and they respond very quickly.
That's great. And do either of you have any examples of times where you've not had such successful communication with your providers? Like if you needed something like, oh, I ran out of my Mestinon or I'm having symptoms, what have you?
I have an example of when I had surgery out of state and it caused me to need to go to ICU having a breathing issue. And they tried to contact the neurologist in the office and they would not respond. So that was an example of not very good communication.
Yeah, I had a difficulty. I live in West Palm Beach, Florida, and my neurologist is there and all my treatment is there. And for work, I'm currently located in Frisco, Texas. So I had to shift my medication from Florida to Texas, which I thought was going to be a simple thing, but go figure. So what I found out through the process is I either had to get a neurologist in Texas if I wanted to continue at home treatment, or I could stay with my doctor in Florida, but I'd have to get my treatment in an infusion center. And the process, so you have to go to the insurance company and you got to get your script changed and reordered and stuff like that. And, the difficulty anytime you have multiple people involved in a sort of a treatment change, I ended up missing a cycle of my medication, and that was unfortunate. But
And so both of you have had, again, kind of lengthy diagnostic journeys. You've worked with a number of different neurologists. And so from your perspective, are there any barriers to like successful shared decision-making with a provider? Like, what are things we could do better to more successfully partner with our patients in making decisions about how care is delivered?
yeah, I don't think it's doctor wide. I think the key is to find the doctor that knows MG. Because I think once you find that doctor, some of those walls and barriers just fall down. It's not, you find a doctor that knows more about the disease and the treatments than you do. That's a good deal, I think.
Yes, definitely.
Very much so.
Okay, no, that's excellent. Yes, and I'll just put a plug in for Partners in MG Care through the MGFA. So if you need to find an MG expert close to home, you can certainly go to the website and search that. And
Could I add
yes,
too that
please.
I think just feeling heard and an appointment is a very limited amount of time. But just asking questions and not just talking, but listening as well.
Listening as well. And I think we've had this conversation before, but also being prepared for those visits, right? And having a list of priorities, of things you want addressed. Yeah, being prepared going in.
Yeah, I'll add, I went through a process where I didn't think I was going to be able to keep working at one point in time. So I was talking to my doctor about disability and what does that mean? And, you know, that's not up your alley, I don't think, but he was very supportive of that whole process and, you know, taking some time to talk to me about my options.
Right. And I think it's our job, even if it is not our expertise, to hook you up with the resources that you need. So for example, in my clinic, I have an amazing social worker who also runs our MG support group, is very familiar with the disease. And she is an asset to our patients who are seeking disability to answer questions and point them in the right direction. So yeah, we should certainly be helping to show you the way, even if that's not our area of expertise. So with all of that, I know there's a lot we didn't touch on, but you know, for both of you, if you have like 2 to 3 like take home points for our audience in terms of how we can successfully work together between patients and providers.
Yeah, I think, and we've talked, you know, we've hear this in the room from time to time, but I think one of the first things is to advocate for yourself. Clearly, you know, if you can go into a doctor's office and, oh yeah, everything's fine, you know, well, that's what the doctor hears. They're going to let you leave and think everything's fine. But yeah, you really have to be open and honest. And I usually write down a number of questions before I go in so I can get, you know, I can stay on point and get those answered. The other thing I would suggest is if you do have an opportunity to participate in trials, I think it's a great thing to do. You know, not only, you know, for you individually, but for others. It taught me so much, I think, about the disease and the options that are out there and helped educate me beyond.
I think don't settle. If your doctor doesn't feel like it's a good fit, find another one. And when you're sick and you don't have a lot in the tank, that is a daunting idea. And I know I felt like it could look like I was doctor shopping or diagnosis shopping, and I was doctor shopping. But it's paid off and it took time. And I've advocated my whole career for other people, and it's very different to advocate for yourself. And when you feel not believed, it really dampers the confidence, I think. So remember who you are and connect with people who, in the last speaker who was talking about people who have been through it and can be a mentor and learn not only about the disease, because you need to be an expert about it, but also about you and how it affects you, and learn your body so that you can better represent yourself and your situation to your doctor.
Yes, and I think to echo something you said and Dr. Rosenfeld said earlier, I mean, always be questioning your doctor. Can I do better? Can I, you know, get to minimal symptom expression, right? Can I essentially go into pharmacological remission and feel almost back to my normal self? And so don't settle, right? Don't settle. If you're not where you want to be, raise that question of what other options are out there for me, or what could we be doing differently? Or maybe a clinical trial is the right option at that point, but it's worth having that discussion for sure. And then I will just say one thing that's sort of related, but not exactly on topic. Just assume that all other physicians out there know nothing about myasthenia gravis. And so, you know, I say that because my patients, you know, I always tell them, if someone tries to start you on a new medication, do a timeout and message me before you take that antibiotic, right? Because that physician in the emergency department or urgent care more than likely did not check the list of drugs that are contraindicated in myasthenia. And so you have to protect yourself and advocate for yourself and ask that question. So always do that before surgery, anesthesia, all the things. So with that, I know we have a few minutes. This is a sort of different format with the patient panel, but we're happy to take questions if anyone has any. Do we have a mic over somewhere? Thanks. Are you comfortable sharing your medication?
Are we allowed to? Is that okay?
I think that's your choice.
Yeah. I'm currently on Mestinon, 4 tabs 4 times a day. And like I said, that helps from the neck up pretty much. And then about 6 months ago, I've started Hytrulo, and seeing very positive results. Have you been on CellCept or No, no immunosuppressants.
I'm currently on Vyvgart Hytrulo for about a year, and I just recently started CellCept, as well as for the trip here, my neurologist sent me with some prednisone, which I have never tried before. But I was very thankful. But there were reasons why those weren't prescribed in the past. But I feel comfortable with them now. So I'm not on any. He gave me 5 milligram tabs and wants me to reach out if I need them. And he's very cautious with that, he said. So, sure.
Any other questions, or anyone want to share something that's gone very well for them, or an experience that perhaps could have gone better? So we can learn from your experience.
My question is a little more about how you handle the cost of these newer drugs when you're talking to patients. And because I know in our situation, it's been a fight with the insurance companies. So just if you could speak to that.
Oh, thank you. That's an excellent point. Yeah. So as we're sort of weighing the risk and the benefit, we also are discussing cost and everything else, like I said, administration route and frequency of treatment. And so I will be honest with patients always upfront if we're thinking about starting one of these newer therapeutics, that even if I say it's indicated and recommended, it might not be approved. And even if it's not approved, then there's a whole process, right? So there might be a denial, a peer-to-peer, an appeal process, and that can be extremely lengthy. And I was just telling some folks at lunch, like my team, we actually had to hire a new nurse just to cover our myasthenia patients, and then also hire someone else just to do insurance authorizations with these newer therapeutics, because the volume has been so great in trying to navigate this. And so I'm honest upfront, because the last thing I want to say is you need X, Y, or Z, and then it gets denied, and then it's, well, why? Why can't you get it for me? I mean, it is a very challenging time to navigate the insurance situation for a lot of different policies. And then home infusion versus, in facility and all of that too. Yep. Great question.
Trials are free.
Trials are free. Might have a placebo arm, so you have to consider very carefully who qualifies for that. Okay, any other last minute questions? All right, thank you all for your attention, and thank you to the panelists.